This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 596, recorded on March 31st, 2020. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from Western Massachusetts, Alan Dove.
Good to be here, and it's I actually haven't been outside today, but it looks kind of nice, partly cloudy and moderate weather.
And you're still well.
I am still well, and feeling okay.
Good. And also joining us from Austin, Texas, Rich Condit.
Hi, everybody. It's 70 degrees and sunny. That's 21 Celsius. It's an absolutely gorgeous day. Mother Nature doesn't give a hoot about the coronavirus, apparently.
How are you feeling?
I am healthy.
Are you well? Good.
And our area, let's see here. Texas is still like 10 or 11 on the list of states with, by confirmed COVID cases. And we have 3,351 cases with 49 deaths. More locally, Travis County, where I live, is 206 cases and 2 deaths. So far, so good.
Well, it's probably just going to be later in your state because it's kind of a asynchronous thing, right?
Yeah, I don't have the latest counts from Massachusetts. Our case counts are going way up because they drastically ramped up testing.
Well, I can give it to you. Massachusetts is 57-52 with 56 deaths.
Yeah, and they just had they just had in my area Holyoke, which is just north of Springfield. There's a soldiers' home, like nursing home, large building nursing home for veterans. And I gather 11 of them have died in recent days, potentially from COVID-19, but we don't have the data on that. And the headline on New England Public Radio is "What the hell happened?" So things are. I've got another thing that we can mention that my wife forwarded to me.
There are going to be lots of stories like this of local outbreaks and local, isolated spreading events. Ran across one recently about a choir that decided to rehearse despite warnings, and it caused a big problem. There was a lot of
super spreader event. Yeah.
Yeah, I think it's important to remember that there are a lot of infections going on that we don't know about.
Yep.
A lot. And they are slowly coming to the fore. Some of them not, 80% we probably won't know about. So This is all happening all over, and so it's going to explode.
I really, really hope that there's a whole bunch of infections going on that we have not a clue about.
Yes.
Okay. So that, in fact, the population is approaching herd immunity a lot faster than we know.
I agree.
But we won't know until this is over.
Yeah.
So we have, 175,000 in the U.S. I think we're over 1 million easily. And I think you're right. I think it's going to immunize a lot quicker than we think, but we'll see.
Yeah.
We'll see. If you like what we do, consider supporting us. And a lot of you have done that recently. We appreciate it greatly. Microbe.tv/contribute. I want to apologize for the sound last time. I know it's not good, and I was a little overwhelmed. I'm doing this at home, for the first time. My studio at the lab is great. It's easy to do everything, but we had to double up people, and so it didn't work, but we'll fix it. Also, I appreciate corrections and comments, but don't be nasty. We're virologists.
Yeah.
Our expertise, and I speak for me and Rich, there are a lot of things that we're outside of. So we're trying to do our best. And the cool part is you're helping us. A lot of expertise.
I'm outside of my expertise on everything because I'm a journalist. So.
No, you know everything though, right?
Right. That too. Yes. It's both of those things.
Yeah. This is an interactive enterprise. Okay.
Yes. We
interact with each other. And we also, I think one of the things that makes this really a great show is that we interact with the audience. And we do our best, but we screw up. If we screw up, let us know.
But do it nicely.
Nicely. Okay.
Let's do it nicely. That's all I ask. Because
and we'll say, yeah, we screwed up. I mean, I screwed up big time early on, just in terms of forecasting, because way back when, before it had seeded itself or just was starting to seed itself globally, I was still saying, nah, this is going to burn out. It's no big deal, you know?
Oh, when this is over, I'm so going to make a bunch of clips and put them all together. And then we'll get to the current part and we'll include those as well. Yeah, just be nice, because everybody's on edge to different extents, and being not nice doesn't help. Right. So that's what we ask. I was talking to a journalist this morning, and she pointed out this interesting COVID-19 treatment and vaccine tracker, which is done by the Milken Institute. It's very nice, and they have a nice pie chart in the beginning, and then you click through and you can see all sorts of products, et cetera, with a lot of detail. And they're updating it regularly. So it goes on for many pages.
Yeah, that's great, because we get a lot of questions about, what's being investigated. Well, here's the answer.
Yeah.
It's all
and
here.
the answer is pretty much everything. This is a huge number of groups and companies working on stuff, which is great.
So you found something here, Rich?
This, of course, came from my old reliable source, Ed, actually his daughter. That's from IHME. What's that? Hang on. I'm clicking on it here. Doesn't tell me what that is. I hate it when people use these acronyms for their companies and then they don't tell you what they are.
Yeah.
It's some sort of health metrics organization. And these are projections about how many cases there are going to be, how many deaths there are going to be, and in particular, how many beds are going to be needed in various hospitals. They got two graphs here. One is deaths per day, and another is hospital resource use. Okay, and the hospital resource use is very interesting because they have a grip on how many beds are available, and they predict how many are going to be needed, and therefore what the shortage is. And you can do this. You can see these data or predictions for the whole U.S. or for individual states, if you like. And this is all assuming that social distancing restrictions stay in place. They don't make an attempt to model what variation in those behaviors will have.
This is a neat site, and the graphics are very well done. I will just put out the caution that I also put on Twitter about all these types of things where there's, a graphic that seems to have some definitive answers and numbers. This is coming from the data we have, and the data we have are still really, really poor. There are definitely people dying of this disease who were never tested, and it's not counting as a COVID-19 death. So even early on we thought, well, at least we're getting the death count right, because when somebody's dead. But if it's not counted as a COVID-19 death, then it's not going to show up in these models. And so we don't know how big that population is. We don't know how big the asymptomatic population is. So there's a lot going on here that could be incorrect in either direction. And just bear that in mind when you're looking at these things.
Yeah, it seems to me that the number of actual infections would make a big impact on these curves. And but even as they predict, this thing is ending around July 1st, which may be good news, right? But we don't know. It could end sooner, depending on how many people are infected.
It could, and as Rich mentioned, if it turns out that there's a whole lot more asymptomatic spread than we thought, then that'd be wonderful. And we would get herd immunity faster, and spread would stop faster. We don't know.
Yeah.
By the way, the IHME is the Institute for Health Metrics and Evaluation, an independent population health research center at University of Washington Medicine.
Okay.
Very cool.
Okay.
Very cool. I like that very much. Let's see if there's a sit rep today. No, there was one yesterday from WHO, but not today yet. They have nice epi curves of the whole world, and
right
now when you put China in the context of the world, it looks almost like a blip.
Right. Yeah.
And we were so worried about it, and now compared to the rest of the world, the China epi going up and down is quite small.
Yeah.
Compared to the rest. Anyway, this is a very cool, this IHME, very cool site. And you got some interesting info for us, Alan?
Yeah. So my wife is a physician, and she's boarded in both Massachusetts and Connecticut. And she got an email from the Massachusetts Department of Health that she forwarded to me with a 2-word comment, the first word of which is holy. And it's
the second word is not cow.
Is not something we're going to say on the show. Yeah. The Massachusetts Department of Public Health and Office of Chief Medical Examiner remind physicians and everybody else it's imperative to indicate a proper cause of death and sign death certificates immediately in order to facilitate mortuary services. And they give a link. We all need to work together in this state of emergency, etc. So, in other words, I guess people in Massachusetts, which we're not really thinking of as having as bad a situation as some places, are dying fast enough that medical folks are not even having time to fill out the death certificates. So that's pretty grim.
That's pretty grim. My wife and I have been having this conversation. It'd be interesting to hear Daniel's comment on this, but it's interesting how quickly the healthcare system becomes overwhelmed.
Yes.
And my naive assumption is that that's because, kind of similar to the airlines, they normally operate as close as they can to capacity. And taking on anything more, well, obviously, I'm sure that most of these places have some sort of a plan in place for a disaster striking, but this is an uber disaster. So, yeah, this is a problem that in disaster preparedness people talk about surplus capacity. Like, what's the surplus capacity of your phone system, or of your electrical grid, or of your hospital system? And the problem is that when all of these systems are run as for-profit entities, or effectively run as for-profit entities, surplus capacity is a loss. I mean, you're not using it 99% of the time. And so it doesn't pay to have a lot of extra capacity in the system most of the time. And then something horrible happens, and that's when you need government to step in and with the stuff you need. And so that's where we are.
So I wanted to ask both of you what you thought. So far this year, I was looking at the flu site, CDC flu yesterday. They say we've had about 50 million infections of flu alone, 700,000 hospitalizations, and maybe 50,000 deaths. So why can we handle that? I don't get it.
That's a kind of an ordinary-ish flu season. That's a little worse than ordinary, but 30K or so is an ordinary flu season, right?
So we're able to handle that. That's what you're just saying.
Yeah, that's part of the normal traffic.
That's normal traffic, and every clinic and hospital expects that from fall through early spring, there's going to be flu, and patients are going to show up with bad flu, and some patients are going to need to go to the ICU, and that's why you have an ICU. And the system is built to handle that kind of a surge, and bear in mind that flu season, I mean, nominally starts in September, October, and runs through right about now. So this is all spread out over several months, whereas COVID-19, it's more like spread out over a few weeks. You get a whole bunch of people showing up, and the need is just so much greater.
All right.
Well, my hope is that as a result of this, there will be a rebooting of some federal program, I assume federal program, that it's a pandemic preparedness program that can help deal with this kind of thing. And as I agree, it can't come from private enterprise because
private enterprise is part of the solution. And in fact, post Amerithrax attacks after 9/11, the anthrax in the mail thing, there was this massive mushrooming of funding for biodefense, and that a lot of that overlapped with pandemic preparedness, which was good. And so the national stockpile, and they stockpiled stuff for occasions like this, including things like personal protective equipment. And private industry is obviously producing those products, and it's an important partnership that the government works with industry and gets this stuff on board and keeps maintaining it. But then after, decade and a half or so of not really using the stuff, maybe we can cut some costs here, maybe. And that's when the government gets into the same attitude as business of maybe we don't need this surplus capacity. And so a lot of this stuff got cut back, especially in recent years. And now here we are. That's the problem.
Yeah.
Public health, when it works perfectly, nothing happens. And then when it fails, you really need to have been prepared for that 6 months ago. And it's the kind of thing that's very hard to illustrate to the public, although hopefully now it'll be a lot easier to get that message across.
I think it will happen at state levels, though, because we're not going to have federal guidance on this.
Not soon.
Nope. Maybe not for another 4 years, right?
Who knows?
Just Sunday, the FDA authorized emergency use of hydroxychloroquine and chloroquine phosphate for the treatment of severe COVID. And they say, this is a very interesting letter. We're going to put a link to the PDF where they justify why they're doing it, saying that, so far the results, while they don't meet our normal standards, are suggestive, and therefore we think it should be used for very serious COVID-19 patients.
Based upon limited in vitro and anecdotal clinical data. Yeah.
That's an unusual step.
Yes.
Very unusual.
On the other hand, these are compounds that have been used in patients for a long time. So there's a lot of understanding of what the tolerability is and how to use it and that kind of stuff. So it's not as if it's a totally novel compound. It's something that's in use.
Yeah.
Right. And I think also the FDA was aware, especially after this got so much hype in the media, that a lot of physicians were just going to go ahead and prescribe this off label. And in fact, in the Lipkin show that you had, his doctor prescribed it, and I think Ian seemed to still a little, I don't know if it worked. And maybe it did, maybe it didn't, but a lot of doctors want to prescribe it, and they're doing that off label, and there's some liability attached to that. So I think the FDA is stepping in and saying, okay, we're just going to let people do this. We're going to give you an emergency use authorization that this is okay.
Reminds me of the early days of the AIDS epidemic.
Sure.
Oh, yeah, sure.
There was clamoring for therapies, and they wanted the FDA and other agencies to, speed things up and get these things into patients.
And they did. They fast-tracked a lot of them,
yeah.
So how does this work? A physician applies to the FDA for this for their patient?
I don't think they need to apply. I think this is just it's now authorized for emergency use. But we can ask Daniel Griffin when he's on Friday what the specifics are.
Yeah, he's going to tell us about a clinical trial he's going to do.
Yeah.
On this. So this is based on, a few trials which have been met with a lot of criticism. There was a new one released, Saturday or Sunday from the Marseille group, clinical and microbiological effect of a combination of hydroxychloroquine and azithromycin in 80 COVID-19 patients with at least a 6-day follow-up. And there are more clinical descriptions provided than in their first study, which Daniel was very critical of some time ago. And they say that, there was some clinical improvement, but the virological decrease is quite striking in these patients. So unfortunately, there are no control group. And so, many people don't like that. And that's understandable. But on the other hand, there is somewhat of a history of how long it takes for patients to become negative after treatment. So this looks like it might be improving, but we do need more trials.
Yeah.
And there will be.
Yes.
There will be for sure.
Yeah. And this paper, we had a little discussion on Slack about it. And it's got some good stuff and some not so great stuff. But my objection, I think, mainly was that they seem a lot more hyped about their data than maybe they ought to be. But the thing that I really liked about it and would love to just point out here is they did viral cultures, right? And this is something that has been missing in a lot of this literature. Is people do PCR and they say we got an effect on the virus because the PCR shows that it declined. And here they actually cultured the virus and showed that culture positivity goes down, and it's actually at a different rate from the PCR. And so, maybe some more people ought to be culturing this virus.
Mm-hmm. Yes, I agree.
But yeah, this trial was not by itself all that impressive in terms of patient outcome.
The other one is a trial out of several groups in China.
Mostly Wuhan University.
Wuhan. 62 patients, admitted to a hospital at Wuhan University, and they were enrolled. 31 got hydroxychloroquine, and the others didn't. And they looked at the time to clinical recovery, clinical characteristics, radiological findings, and they found an improvement in time to clinical TCC, our time to clinical recovery, body temperature recovery time, and cough remission time significantly shortened in the treatment group. Larger proportion also had improved pneumonia. Okay, so they're another separate independent group, and they didn't look at virus here, right?
They didn't, but I was actually a lot more impressed with this paper because they're very modest in their claims and saying, this is a small study. We did see some apparent improvement in time to clinical recovery, which is a very relevant measure. Because really, if we tell the physicians that we're decreasing the viral load, we virologists are all excited about that. And the physicians say, yeah, but how's the patient going to do? So time to recovery looks like they've got maybe a real effect here. And they're, they're modest about it in the conclusion. They even say we need bigger trials. But they did a control group. So
right, they did a control group. This is a legitimate controlled trial.
I liked this. I liked this paper better, even though there's a lot less virology in it.
So clinical reports are now starting to come out in the peer-reviewed literature, which is always nice, as opposed to bioRxiv and medRxiv.
Right,
and there's one in New England.
Yeah.
One is the two papers we just mentioned are preprinted.
Not reviewed.
This one is in the New England Journal of Medicine, COVID-19 in critically ill patients in the Seattle region. So this is a study of patients from 9 Seattle hospitals who had COVID-19. And they say during the first 3 weeks of the outbreak in Seattle, most common reasons for admission to ICU were hypoxemic respiratory failure, leading to mechanical ventilation, hypotension requiring vasopressor treatment, reduced blood pressure, or both. And mortality among these patients was high. So this is a good kind of summary for clinicians who want to know about characteristics of the disease. And it's very detailed, and you have numbers and lab parameters and so forth, x-rays. And this is the kind of thing we need to get an overall picture of this disease.
Yeah. And this is the ICU patients. These are the ones, These are the ones we need to worry about most.
That's right.
This is an interesting chart here. What's this figure 2 that shows graphically sort of the course of disease with 24 individual patients?
Yes.
Right.
And finally, as you may know, I think we've mentioned the use of convalescent plasma therapy, right?
We have.
So,
yeah.
I no longer remember what we've talked about, unfortunately. But this is another study out of multiple institutions in China. Feasibility of convalescent plasma therapy in severe COVID-19 patients, a pilot study, 12 different institutions in China. Mm-hmm. They treated a number of severe patients with one dose of 200 ml of convalescent plasma, which they showed have neutralizing antibodies to SARS-CoV-2. And they saw improvement, clinical improvement. However, they were also giving them other other
Well,
treatments.
right. Yeah.
So it's hard to know. And I think they did ribavirin and another antiviral whose name is escaping me, which it's one we don't mention very much.
This reminds me of your conversation with Mark Dennison about ribavirin, which I thought was absolutely fascinating, because that's a drug that looks like a nucleotide. So it gets, if I understand it correctly, its mechanism of action is it gets incorporated, but it's mutagenic, and it's so mutagenic that the virus dies of mutations. Okay, but coronaviruses have this exonuclease. It's a proofreading function, and it can counteract the effects of ribavirin. So it's not effective against some coronaviruses, at least in Mark's hand. That's fascinating. Just amazing.
Yeah. He said basically it doesn't work. Ribavirin doesn't work because of the error correction.
Right.
Amazing.
There are some limitations to the study. Patients received other standard cares. All patients received antiviral treatment, despite the uncertainty of the efficacy of the drugs used. Some patients received glucocorticoid therapy, which might interfere with immune responses. So this is the kind of thing where, you're trying to treat patients with all kinds of things just to save their lives, and then you decide to publish it, and it's not all that conclusive. The one thing we can say is that the serum therapy didn't make their disease worse.
Right. And it's critical to get these, as dirty as the data are, and we can think about, well, you could arrange a study to do this better. It's critical to get these kinds of results out and say, okay, well, at least the antibodies, the convalescent serum didn't make it worse. Now somebody can go and test convalescent serum, and maybe in patients who are a little less sick.
And it's cool. We got the whole world involved here.
Yes.
And it's all amazing. Happening in real time and very quickly. It's great.
That was the primary goal, by the way, of this study, just safety of the transfusion.
Safety of the transfusion.
That point is very important. I was thinking of that today. At every level, people are responding, not just clinicians taking care of patients and doing clinical trials, basic scientists, but, first responders, resource management people, computer people making all these amazing models and graphs. Everybody is responding. So I got this impression back in January that not much was happening. And that was probably true here in the U.S. Yeah. But now it's amazing. And I do think that's going to make a big difference in the end. People are really kicking in.
Even the people who are not directly involved in researching this or responding to it, and they're not at the front lines, the people who are listening to the stay-at-home orders and are hanging out and, gosh, I'm bored out of my mind. I'd really like to get together with my friends, but I'm not going to. They're part of this too.
Yep.
That is helping, and that's really making a difference. And
I watch my daughter and my son-in-law. Both of them are teachers, one at the university level, the other at the elementary school level. Actually, the elementary, my son-in-law is a principal. And, they're putting school online.
Yeah.
All right. That's a huge effort that happened quickly. It's amazing.
And I have thought forever that we should pay and treat our teachers better. And my belief in that has only been rigorously reinforced by the past few weeks. And I think a lot of people, who are now trying to play the teacher at home are having the same realization.
All right. A few episodes ago, we were talking about the blood supply, what's going on. So I wrote to Eric Delwart, who was on a previous TWiV, and he writes, as you've reported, there is definitely SARS-CoV-2 RNA in plasma from some COVID-19 patients. Blood donors must be afebrile. Whether those who develop fever a few days post-donation were viremic at time of donation is the subject of ongoing studies in the Bay Area and Seattle area. I can imagine that you're infected and you don't even get febrile, right?
Right.
Sure.
Blood banks are also gearing up to measure SARS-CoV-2 antibodies prevalence across entire country to finally measure the rate of asymptomatic infections and get more accurate case fatality rate. That's great.
Great.
Yeah, because blood banks are perfect for that, right?
Absolutely.
Yes. I think we mentioned that before. Plasmapheresis is also being started on recovered COVID-19 patients who is RNA negative to see if their plasma has therapeutic value. There are also pathogen inactivating methods used for some blood transfusion products that kill all infectious agents by cross-linking their nucleic acids. That's cool.
Mm-hmm.
Many viruses have impacted transfusion safely, namely HIV, HBV, HCV, West Nile, and Zika virus, and the system is geared to detect and exclude contaminated donations using highly sensitive PCR and TMA nucleic acid tests.
What's TMA?
That's it. Yeah, let's Google that.
Transcription-mediated amplification.
Okay.
Isothermal single-tube
right.
amplification.
It's one of these PCR
enzymes.
Alternatives. Yeah.
You use RNA polymerase and RT. So using RNA polymerase, Rich.
Great. This must be, there's this new rapid test that's being deployed from Abbott Labs, I think.
That's right.
A quick nucleic acid test. I'll bet you that's a TMA test. I tried to look into it and find exactly the technology. All I could find out is that it was a nucleic acid test that was isothermal.
Right.
And it was a small benchtop instrument. So I'll bet you that's it.
There is a blood shortage due to absence of blood drives in closed high schools and companies. Going out to donate blood is allowed and safe for quarantined people looking to contribute to their local blood bank. Thanks for ramping up TWiV. It's the least we can do.
Yeah.
Thanks, Eric.
Thank you, Eric.
Good to hear from Eric.
Yes.
Alan, what have you got for us here?
Yeah. So I got this via Twitter. Someone who asked to remain anonymous. And this is regarding, I don't recall whether we talked about this. Kaiser Permanente, one of the biggest health insurance companies in the country, sent letters to lupus patients right after Trump endorsed using hydroxychloroquine for COVID-19. These letters went out to patients who were taking hydroxychloroquine, and that's used as a treatment in lupus because it's helps prevent the autoimmunity of the disease. And the patients got these letters saying your hydroxychloroquine prescriptions will not be renewed because we need it for treating COVID-19. Thank you for your sacrifice. Yeah, this is vintage insurance company behavior. I know probably some of our listeners are in the insurance industry, but wow. So this private message I got on Twitter, full disclosure, I have a personal interest in the Kaiser Permanente hydroxychloroquine matter. I have lupus and rely on hydroxychloroquine. I'm all too familiar with how quickly it stops working if you miss it. Second day off starts a downward spiral. Prescription issue resulted in 5 days off once. It took me 2 months back on the prescription to recover. I'd hate to imagine what would have happened if I'd had to stay off it. Luckily, I'm not a Kaiser Permanente patient, but I think there's a very real risk that other healthcare providers and insurers may follow suit. Lupus patients without immunosuppressant treatment are more likely to have severe reactions to infection due to overactive immune systems and compromised health from autoimmune damage. With hydroxychloroquine, we are at risk due to a suppressed immune response, but at least the lupus isn't attacking us as much. Choose your adventure. But here's the kicker. Take a lupus patient off hydroxychloroquine, the rebound flare-up is much worse than a never-treated flare-up. We'll be sitting ducks for COVID-19. So I hope that Kaiser Permanente
rethinks
that, because that is just horrible. I mean, yeah, demand for this drug is going to go way up, especially now that we're starting to get some real data on it, and it's looking kind of promising. But don't take off patients who are already on it.
It's crappy. It's really not nice.
No.
That's what we said at the top of the show. Be nice.
The first thought that occurred to me from observation of the health insurance industry was that this was just an excuse to avoid paying for some prescriptions. But I mean, that is maybe a little harsh, but this is just not good corporate behavior.
No, the alternative is to try and ramp up the production of the drug,
which
right?
is what I think is already going on, and I think the drug industry is well aware, and I think the insurance companies should not be monkeying around with people's prescriptions preemptively on the assumption that they're going to redirect this stuff.
Rich, can you take the next one, please?
Okay, just a note here that since we have something in excess of 100 pages of emails that we're trying to get through, these are being abbreviated.
Yes.
Alan has done a wonderful job of going through and editing these, so we're going to excerpt them, but the full content of all the emails are posted on the TWiV website after all this is over. So, Francesco writes, a reputable private medical clinic here in Hong Kong is offering tests on blood that look for evidence of antibodies, which suggest current IgM or previous IgG infection. I have two questions. Can this type of test clearly differentiate between current and previous infections? And two, I received the following comment about on the above COVID-19 test from a doctor who is unrelated to the clinic offering the test. Quote, with virus mutation, having antibodies to one strain and thus having immunity to it wouldn't mean that you are immune to another strain, end quote. Putting aside the question of the type/duration of immunity for this pandemic, is the comment about different strains and different antibodies correct? Okay, so first, can the test clearly differentiate between current and previous infections? It can distinguish a current infection or a recent infection because IgM is the antibody that comes up first and then wanes and is replaced by IgG. And you'll first see IgM, within about a week of being infected. Mm-hmm. So it's not a diagnosis for whether or not it's not a good diagnosis for whether or not you have the disease because there's a delay in its coming up. But if you're IgM positive and IgG negative, that says that you either have a current or a very recent infection. And the tests measure both. So you can have a test result that's IgM and IgG positive, which means that you're kind of on the crossover. Okay, you've started making IgG, and I don't know the time scale for that, when the IgM starts to be replaced by IgG. And if you're only IgG positive, that says that, yeah, you had a previous infection. It was some time ago, but it doesn't tell you how long ago. Could be a long time. Could be a short time.
I'm looking at a graph right now. So
Okay.
Days after immunization. So, within a couple of days, you can see IgM, 7 to 21 days, right? It peaks. And then IgG is not too far behind, but then IgM goes down and is gone by 60 days.
Okay.
And then, IgG persists. So I think you got it all right. The key is that even if you have IgM, it could be well past the infective stage, right? Because it's 60 days. In this case, we know this resolves sooner than that.
And
most people.
I recently, in some correspondence with Ed, Ed and I have our own little sort of TWiVlet going on the side. Went through exactly how these rapid tests work, and they're fascinating. They're just amazing. But basically, it's this little, maybe 3-4 inch long, an inch wide cassette with a long window in it and a little well at one end, and you stick a drop of blood and some buffer that comes with a kit in the well, and you wait, I don't know, somewhere between 5 and 15 minutes, and there's a control stripe that shows up that tells you that the kit worked, and then there's 2 more stripes, one for IgM and one for IgG, to tell you whether you got either of those. And the molecular, the biochemistry or whatever, the immunology, whatever you want to call it, underlying it is absolutely fascinating. But we could do that another time, maybe.
Yeah.
It's just like having a home pregnancy test. You pee on it and you see a band, right?
It's amazing.
So these should be available for common folk like us.
I'm sure that'll happen at some point.
Yeah.
Again, this is an incredible example of these things coming online really quite quickly. Of course, all the technology is there because these tests are available for other diseases. So it's just a matter of using the new sequence to make a couple of recombinant antigens from the virus and to make a monoclonal antibody for a control. Okay. And other than that, the whole thing is all put together. But it's amazing.
It's the manufacturing and distribution, which the chains are already there for it. So these companies just pivoted and said, okay, we're making these tests now.
So his second question is the doctor asking, it's basically, can the virus mutate and so you wouldn't be immune to it? And our understanding, my understanding with SARS-CoV-2 now is that there's no evidence that it's going to undergo what we call antigenic drift.
Right.
Okay. That it will be SARS-CoV-2 for the foreseeable future. And once you mount an immune response to that, you'll be immune to it. And there won't be, as far as we know, new strains coming up that to which you will not be immune. These things, the human coronaviruses seem to be pretty stable over time. Yes, they can accumulate mutations, but they are of essentially no consequence.
And as viruses go, these coronaviruses, because of the proofreading, are actually more stable than a lot of other viruses. Probably what the doctor is thinking of is that this is analogous to flu, where you do see antigenic drift and antigenic shift, and where you get different strains circulating all the time. But there's no evidence, as Rich said, that SARS-CoV-2 is doing any of that.
And he's writing from Hong Kong, where he says it's 68 Fahrenheit, 94% humidity. Yeah. Holy cow.
Those are big droplets.
Yes.
Alan, can you take the next one?
Sure. Renee writes, and this is about a conversation before we had where people were asking about gas pumps. You implied the social media alarm, which I haven't seen, about getting COVID from gas pumps is incorrect. This is something I've thought about and use a hand wipe on my hands after pumping gas as a precaution. You didn't follow up, but it seemed like you were implying this isn't something to worry about. Did I misunderstand?
Well, I think you could get it from a pump, right? It's not because so many people touch it. So
nothing zero risk, and fomites are a means of transmission of this. The dominant mode of transmission is contact and droplets, as we've talked about, and that's why you stand 6 feet away from people now. But it seems like the evidence is pretty good that it survives long enough on surfaces that you could get it from something like a doorknob or an elevator button or a gas pump. And I don't recall what we said about this. I wouldn't be super paranoid about the gas pump being like, oh my God, that's the primary source. It's not. But it's not unreasonable to wipe your hands after pumping gas. And personally, anytime I'm out and about, if I touch anything that's, out that other people are touching, I make a point of trying not to touch my face. I act like I'm in the lab and I was just working with something contaminated, and I wash my hands at the earliest opportunity. Yeah,
I don't think you can go around with wipes and wiping off everything you're about to touch. But I do think it probably makes sense to carry a thing of hand sanitizer, if you can find some, in your car.
Sure.
So when you come out from shopping or you're finished pumping gas, you use the hand sanitizer. Early on in this, there was a video about the difference between hand washing and hand sanitizer. And in fact, it was a training video for physicians. And they got physicians walking around carrying little bottles of hand sanitizer, and it instructs you to carry hand sanitizer around and use it at appropriate intervals depending on your behavior. So I think a way to deal with all this is, as we've said all along, wash your hands. You can't sanitize the world around you, but you can take care of the major vehicle for getting stuff from the environment into your face, which is your hands.
Okay, the next two have to do with any cross-reactivity between the different coronas. So the first is from Arthur, who is in Oxford, and wants to know if there would be any cross-protection from classic SARS and SARS-CoV-2. And then we have Eric from Australia, who is chain smoking the recent TWiV episodes and now is in love with viruses. Yes, now you see how I feel. Yes.
Yeah.
And so again, if previous exposures, in particular the common cold coronas, could confer some cross protection. And here's a little comment just made for Rich. Has something like that been done in the past other than with smallpox, cowpox? A related cross-reacting virus. So as far as I know, and this comes up a lot, there is no known cross protection between classic SARS and the common cold SARS and SARS-CoV-2. I've seen nothing that would imply that. Of course, it is still early, and I'm sure this is being looked at because it would be interesting. Remember that classic SARS only infected about 8,000 people globally. So if there is any cross protection, it's not going to make much of a difference.
And that was almost 20 years ago. So those folks are now in the high risk category, a lot of them.
Yes. And then the common cold coronas, I don't think there's even any cross protection between those. So it's unlikely, but I await any corrections.
Yes.
He also, Arthur sent the paper. Alpha ketoamides as broad spectrum inhibitors of coronavirus and enterovirus replication.
Oh, yeah.
These are protease inhibitors, right? Yeah. Protease inhibitors. So the coronavirus is like our beloved enteroviruses, Alan.
Right.
They have proteases encoded in the viral genome. And so, yes, protease inhibitors are potential antivirals. But, these are all in vitro studies, and they have to move much, much further, and that will take a long time for it to make a difference here, although they're probably going to go forward for sure.
Yeah.
Rich, can you take the next one?
This is Mira. May I remain anonymous?
It's a good name.
Yeah.
That's it. Dan Savage does that, makes acronyms out of people's signatures, and it occurred to me that this would work here.
Okay, that's a good idea.
The gist of this is, I wonder if a copper insert in a mask could increase its effectiveness. And this person actually talks about making their own home-brewed surgical mask with a copper insert. And Vincent, you have a comment on this?
Yeah, so I've heard of this a long time ago, and the idea is actually to put a copper mesh, right? You don't just want a piece of copper in there, but a mesh that would be intertwined with the fabric. So I asked Michael Schmidt, who studies the antimicrobial properties of copper, and he said they're working on it. They started in January, and it's a matter of how much copper do you have to put in to be effective, right? You have to test it. You can't just throw it in and assume it's going to be. So I don't know when they'll come out, but
this is all based on, we discussed this some time ago, that copper has intrinsic antimicrobial activity as a surface. When stuff doesn't live well on copper, it kills things. People go around stealing copper, right?
Yes,
yeah.
It
is a valuable metal, and it gets looted from places a lot.
Yeah, so I would imagine that these masks are not going to be disposable, or at least somehow recyclable.
Yep. Alan.
Kristen writes to provide a link to the official National Institute of Standards and Technology, or no, I'm sorry, this is ASTM, American, what does ASTM stand for? It's the American Standards Organization. They're kind of like ISO, I guess. These are standards for personal protective equipment, and ASTM has made over 20 of these standards open access for medical masks, gowns, gloves, hand sanitizers, etc., to get that information out so people can use it. And their site is loading very slowly, so hopefully that's all those manufacturers going to the site and reading these standards.
Yep.
Yeah, anyone who wants to make your own masks or gowns or whatever, you should check this out.
Yes.
Right? It's a good thing to do.
Yeah, standard test methods and that kind of thing.
Okay, Rich, can you take the next one?
I'm confused here.
Right, so there's a signature. There's a Margaret who signs...
She had sent a letter to Kristen. That's why they're both on it. So Kristen forwarded us
so Kristen forwarded Margaret's letter.
Yeah, exactly.
Okay, so that was actually, those links were provided by...
Margaret?
by Margaret, who's an assistant professor of library science engineering specialist at Purdue.
Engineering information specialist.
Engineering information specialist, yes.
Purdue would make Kathy very happy.
Yes, and thank your librarians.
Okay, so Ann Min writes, do some languages produce, this is interesting. Do some languages produce more fine aerosol than others? Could this in part explain a few percentage difference in coronavirus transmission between different countries? I have no idea, but what a fascinating question.
What an interesting question.
My wife and I were having this. We were talking about, can you transmit this just talking to each other? And sure. And then I started thinking about, what's going to make different kinds of aerosols. I started thinking about consonants and vowels and that kind of stuff. And so this is an I don't know if it could make any difference, but it's certainly an interesting question.
Well, we had a link that somebody sent to an experiment where they were visualizing droplets being ejected, and they actually tried in different languages. And they said, there are no safe languages, but there might be differences. They did, I remember from that, I think the phrase stay healthy was particularly good at spraying droplets. It's because the T, stay, and then the H is and so I guess languages that do more of that, maybe that would be a really interesting thing to look at. I don't think I kind of doubt that would be significant enough to explain the differences you see from country to country, because there's so much going on in the way places are responding to this. But it's a really interesting question for the future. To what extent does language affect the droplets? She's
got her own little anecdotal observation that's worth reading here. She says she was practicing Russian on Duolingo and noticed that I was shooting tiny droplets of spit towards the screen, which almost never happens when I give a voice command in my Chinese accent in English. That's what made her think about this. That's great. I love that.
Good idea. That's a good question. IW Petra writes, that's I would prefer to remain anonymous.
Okay.
Following your lead, Alan.
Yes, good.
So the individual quotes Ori saying, you actually legally in New York State cannot be removed from a ventilator to give it to someone else. And so is this 100% true, and provides a document suggesting that you could make such decisions, which is a New York State document, which is all about pandemic preparedness. And this is about as far as from my wheelhouse as you could get. I have no idea. Yeah. And someone must know. Ori's not here. He would help us. So Ori's, by the way, someone asked about Ori. He's not feeling well, so he'll be back someday. I don't know. You don't know anything about this, do you, Alan?
No. I mean, I've been involved with other aspects of disaster preparedness stuff, but this is the Task Force on Life and the Law, and it's a bunch of doctors and lawyers and scientists and ethicists, I guess, who got together in 2015 and very presciently developed guidelines on stuff like this.
I mean, it's got the Commissioner of Health of New York State, a lot of other important people here. Yeah. I don't know if it's law, though.
It
is a recommendation, I think.
And a lot, I mean, I know everybody's declared emergencies, and I'm sure, I think emergency declarations change some things, and I just don't know. We need a legal consult to.
This is a 272-page document.
Yes.
Entitled Ventilator Allocation Guidelines.
Yes.
Dated in 2015. And it's just sort of scanning through it. It's plenty complex. It looks like they've thought this through, but I don't know what the summary recommendations are.
Lawyers and policymakers are not known for brevity.
Right.
So they say we're releasing these guidelines, which will be used to assist healthcare providers in the event of a severe influenza pandemic. So should we ever have an influenza pandemic, they write, Yes, we will. So I think they're guidelines, and I think but I'm not sure how that meshes with the law. So
Right.
I don't know. Any lawyers listening, there must be. Please
I'm
weigh
sure.
in. You can find the link to this document in the show notes. But interestingly, the writer says in a previous episode you struggled with the term nerfed. Someone looked it up and got a bad definition. Reconfigured. It actually means weakened or softened, like the soft foam bullets of toy Nerf guns, Nerf footballs, etc. The opposite of nerfed is buffed, made stronger. Clearly, an attenuated virus is nerfed. Presumably, there are also buffed viruses, yes?
Sure.
I think SARS-CoV-2 is pretty buffed.
Well, but it's also, compared to SARS-1, it's nerfed.
I didn't know that. Thank you very much.
We learn something every time.
Yep, that's a gamer term. The game was updated and they nerfed some features.
I mean, I just learned from every email, really.
There you go.
Alan, can you take the next one?
Scott has a couple of questions, mainly about inoculum size, and we were talking about reports of healthcare workers getting very sick and whether the size of inoculum they get matters. Let's see whether that could influence clinical outcomes and maybe explain higher fatality rates in healthcare workers who are exposed to COVID-19 patients. In our work with bacterial and viral pathogens of fish, we see clear relationships between challenge dose and mortality rate for most of the agents we work with. I had also wondered if repeated exposure to virus from multiple patients could mean healthcare workers are being inoculated with a wider range of genetic variants of the virus, which would make it harder for their own adaptive response to keep up. I wonder if there's any evidence in the sequence data that we have so far to indicate variation in antigenic components of the virus. We'll see above on that. That we don't have any evidence of significant antigenic drift or shift in this virus, thankfully. And then in terms of the inoculum discussion, I actually just recently came across this paper where, in fact, I guess it just recently came out. This is another medRxiv report. This is from a group in the Netherlands who looked at healthcare workers in 2 Dutch hospitals in March. And the upshot of this is that the data don't support more severe disease in healthcare workers. They found they went and did let's see what they did PCR to find cases of COVID-19 among healthcare workers, and they found a whole bunch of them who met a case definition based on symptoms, and a lot of them were minimally symptomatic. A lot of them were afebrile and had very mild presentations, and then concluded that this was community spread going on in healthcare workers, and it seems to mimic what you see in the general population.
Yeah, this idea that healthcare workers are going to get sicker has been kicking around. I don't think there's any support for it, but I think it's clear that they have a greater risk of being infected.
Sure,
because they're in contact with virus more frequently.
Yeah. Oh, says we had our first COVID-19 death here in Tasmania this morning. So that is now there. Also points out they had a phone directory delivered to their house last week, so we'll have a backup when our toilet paper supply runs out.
That's ingenuity, right?
Yes, that's right. Got to improvise.
I appreciate the input on his own work with viral and bacterial pathogens of fish, where they see clear relationships between challenge dose and mortality rate for most agents.
Yeah, that does make sense.
Right.
I can't think of a human example, but it
actually, there is one I came across from yesterday doing a norovirus lecture. They do challenge studies with people with norovirus.
Yes.
18 virus particles are enough to make you sick.
Okay. Do you get sicker with a higher inoculum?
I don't know. I just know that's the minimum, because it's, that's why it's easy to get infected, because you don't need much on food or surfaces, right? But yeah, the question of sicker, I don't know. I would have to look up the study, but it has been titrated for some viruses. All right, Rich.
Okay, this is from Andrew. who wants to know, where do you think new infections are coming from during lockdowns like the one in Italy? So I don't quite understand.
So Italy's been locked down for a few weeks, and yet there are new infections still happening.
Well, I think my first reaction to it, I don't have necessarily an authoritative answer, but my first reaction to that is that there's this undercurrent of infections that we have that we're unaware of. Okay, that for all the reported infections, there are probably many times that of infections that are unreported. So this thing is cooking along in the background without us being overtly aware of it.
Right.
Mm-hmm. Yep.
And bear in mind that the infections and case counts are the case counts that show up because of the, you got to come to medical attention and get tested. This lags the actual infection date by a week or two. And then the deaths are going to lag by more than that because they had to end up in the hospital, and then they had to deteriorate, and then they had to get, to a point where they finally died. And that's going to be maybe a month. So that's all of this is all the indicators that we're really keeping track of are lagging.
Mm-hmm. All right. So Trevor is asking about discharge standards. He writes, I found links from the CDC outlining suggested protocols for infected healthcare professionals and hospitalized COVID-19 patients. They appear to recommend a similar strategy to what was mentioned for Chinese patients: 2 negative PCR resolution of symptoms and a non-test based approach, fever symptom-free for 72 hours. As testing availability is a current concern, what are everyone's thoughts about individuals released based on resolution of symptoms? Okay. I think for now we should since we don't know enough about how long transmission occurs after symptom resolution.
Right.
I think we should be still testing. However, it is a PCR test, I understand, and it's not necessarily infectious virus, but it's better than nothing. That's just my feeling. I'd be interested to hear what you guys think.
I agree with you that I don't know. I don't know enough about how long the virus sticks around after the resolution of symptoms. Okay, so and clearly, you don't want to discharge. Well, actually, you could discharge somebody into quarantine.
You could.
Yeah.
Yeah. That's not a bad idea. Yeah. And then you release
I'm conflicted about this.
Yeah, because of the test shortages, right?
I mean, on the one hand, as a virologist, I say, yeah, you want them virus-free before you let them go anywhere. But on the other hand, I feel like you want to get people out of the hospital as fast as possible right now.
Yeah.
You need the bed, and they're only going to they could catch something else in the hospital because, all the existing diseases are still around, and you're in like the ancestral homeland of MRSA and all the other bad things. So get them out of the hospital. But I think Rich is absolutely right. Anybody who's tested positive and been discharged should be told to stay in their house for the next 2 weeks. And I think under the circumstances, that's probably the best we can do.
Yep, that makes sense to me.
All right, Alan, you're next.
Okay, this is regarding, so this is regarding recent discussions where Tony Fauci and Deborah Birx stated models, this is from Victoria, says Tony Fauci and Deborah Birx stated models have projected 100,000 to 200,000 deaths in the United States. I think this is projected to occur by June 2020. It seems 100 to 200,000 deaths by June in the U.S. is way too high. Can you comment on your thoughts and explain the model process? And then second, what are the current guidelines for mask effectiveness? I think we can. I can certainly provide my thoughts. I can't explain the model process because that's not my business. But 100,000 to 200,000. I put a lot of stock in what Tony Fauci says when it comes to things like infectious disease and pandemic management. This is somebody who knows what he's talking about and does his homework. And I'm sure he looked at the different models. I've seen a number of different projections. Some of them are projecting 1 million deaths, some of them projecting more toward this end. I think these numbers are actually toward the low end on the models, at least of the ones, that I've seen. And I think either Tony or Deborah Birx said that this is if we do everything perfectly, we could limit it to only 100,000 deaths. So that's kind of like a goal, as grim as that sounds. But at the same time, I think I saw Tony Fauci was on an interview with one of the networks and was stating this number, and in the very next breath saying, this is a forecast and it could be wrong. So it seems at this point like not an unreasonable number, but we're not going to know. We're not going to know until it's done.
The site that you gave us earlier, Rich, they have a prediction model also for total deaths, and they have a range by June 1st between 40,000 and 140,000. So that's the kind of range we're talking about here. Yeah. That's the best that models can do, right?
Right.
And as we've said, we don't even know how many people are infected.
Right.
The models.
And the deaths, I mean, a lot of as we've said, a lot of the deaths that are happening are undoubtedly COVID-19, but they don't get tested, so they don't get counted that way. So I think that the final toll is going to have to come out much later.
And one of the biggest questions for me is, what has to occur for this to be over? I mean, It seems to me, I keep harking back to the conversation with Ralph Barrick several episodes ago, where he talked about achieving herd immunity, which kicks in at about 70% of the population infected. Now, I don't know, and I also don't know whether this is all going to happen in one wave or if there are going to be multiple waves. Okay, but if 70% of the population is infected, that's something like about 225 million people. And if the case fatality rate is as low as 0.1%, now you're talking 200,000 deaths.
Right.
Okay. So those are the kinds of numbers that run through my mind. I think one of the biggest questions for me is that when this starts to decline, because we've been applying appropriate measures, and bottoms out, say, and there's very few new deaths. We've talked about this with China. What will really be the percentage of people that are seropositive at that point? And will that be enough to prevent a second outbreak once we relax the restrictions? I think these are all unknowns.
And this is an experiment that China is doing first. And I think the whole world is watching very closely to see how that goes.
Yeah.
Remember, China did not have 70% of its population infected, as far as we know. Maybe
as far as we know.
I wouldn't put any long bets on that.
But they didn't have enough deaths to have that much of their
population. I am not sure, again, that we even know that.
Okay. Well, you know what? If they're hiding that, it's really screwing the rest of the world over.
I am not saying that they're hiding that. Just exactly what I was saying before about people dying of COVID-19 but not having been tested before death because the tests weren't common enough, and it could be that there's there might be that much excess mortality and they just haven't realized it yet because it's all just piled up around the country. And
got it.
I don't know.
I keep thinking back to what Ian Lipkin said. He said he's known Chinese scientists for 17 years, and he doesn't think there's any reason for them to hide anything.
I absolutely do not think that the Chinese scientists are hiding anything. I have a little less trust in the Chinese government, just as I have a little less trust in our government than I do in our scientists, just across the board. Actually, I have a lot less trust in our government than our scientists. But so I just don't know what the final numbers are going to work out to, especially since if it turns out that the case fatality rate is a lot lower than we realized and the asymptomatic infection rate is a lot higher, it's possible that China achieved herd immunity with only the number of deaths that they know about from COVID-19, and maybe that's the end of the story.
Wouldn't that be wonderful? Yeah.
That would be wonderful if, thousands of people are dead, but it's a whole lot less horrible than it could have been. And if that turns out to be the case, then that's great news. But we're all going to find out because they're now lifting the restrictions. And if they don't have any more flare-ups, then we can start asking, well, why? And did they, is it because they got herd immunity, or is it because they excluded the disease?
Okay. Seems fair.
Yeah.
Did you read that, Alan? I can't remember. I think you did. Right?
I think I did. Oh, and there was the question, what are the current guidelines for mask effectiveness from cloth, medical, or N95 masks? N95 is more effective than medical masks or cloth. That's about all we can say for sure. And most of this is irrelevant because you can't get masks nowadays anyway. I think that's about all.
And if you could, you ought to buy them and take them to your hospital.
If you could, you ought to turn them over to your local hospital, yeah.
Someone told me, someone who's been in Manhattan, that about half of people walking around are wearing surgical masks.
Wow.
But there's not a lot of people walking around. But
yeah.
I saw George Gao his voice, I heard his voice the other day. So George Gao is the head of China CDC, and we know George because he's an editor at PLOS Pathogens. And he said the reason U.S. is having a problem is because you're not wearing enough face masks. Here in China, we wear face masks, and that makes a big difference. And he may be right, but it's kind of a moot point because we don't have them, right?
Yeah, and right now there's a debate. I gather there's a debate going on within the CDC about whether to advise people to cover their nose and mouth when they go out. And the argument there, a few weeks ago, I said, I have no plans of wearing a mask out in public. That's why. But now I'm kind of coming around to the view that if something's not obviously harmful and it might help, maybe we ought to try it. So my standard on that has changed. And the other thing that I've seen pointed out, which is a really good point, we do know that putting masks on infected people reduces spread.
Right.
So this notion, I had been thinking about it as wearing the mask to protect yourself from being infected, but perhaps the better way of looking at it is, since most of us don't know if we've been infected, maybe think about wearing the mask to protect others from you. And if everybody goes around doing that, you could reduce spread. So that might be the way to think about it. Mm-hmm. And I think the CDC is now considering some kind of advice around masks, although, as we've mentioned, it's you're not going to be able to buy them.
Rich, can you take the next one?
So this is Katie, correct? Another letter about infectious dose versus severity of disease. You all were skeptical in a previous episode that the severity of COVID-19 disease in otherwise healthy young people could be explained by the infectious dose. If I have that right, could you explain more about why the amount of infecting virus would not be an important factor? She has a PhD in immunology and has done some lab experiments with flu in this regard, and says, talks about infecting mice with influenza. She says, I'm totally ready to believe that pipetting virus in saline into an anesthetized mouse's nostril is not the same as someone coughing in someone else's face, but I'd be interested to hear more. First of all, in this letter, it seems to me there's two questions here. One about severity of COVID-19 disease in otherwise healthy young people, and the other about infectious dose. Because I don't recall the conversation that she's referring to, but I don't recall that we were trying to explain disease in healthy young people in terms of infectious dose. And personally, I wouldn't. Okay, because I think that there are, in referring to discussions we've had in the past, physiological differences between adults and children that can account for the difference in the severity of the disease, or at least that's we don't know exactly why it is, but that's the kind of thing that's looked at. In terms of infectious dose, I am equivocal on this one. We just looked at a letter that talked about in an experimental situation, yes, you can get a dose response in terms of mortality and disease. I don't know that we have evidence in people, and I really don't know what the answer is. I kind of see this as, you get dosed with a certain amount of virus, and it seems to me that regardless of the initial dose, in a natural situation, there's going to be a tremendous amount of amplification before you show up with symptoms. Right. So I have a hard time. I could be dead wrong here, but I have a hard time believing that the initial dose is going to impact much on the severity of the disease. On the probability of whether or not you get the disease, yes. But on the severity, I'm not so sure. But that's just
so what she's talking about is not really severity. It's whether you get sick and recover or not, right? So the mice get less virus, they recover, and you give them more, it kills them. I guess that's severity.
That's severity, right.
So certainly in experimental situations, there is a relationship.
Yes.
What we just said earlier, we don't have, and it could in humans, but we don't have any data to that effect, right?
Yeah, that's the only thing. I mean, I totally get how this works in multiple animal models, and my only reason for thinking it might not be the case in humans is we just don't have a good example, and I don't even know how you structure that, but some example of a virus where there's some situation where people can get a huge dose and some situation where people can get a small dose, and you get infection in both cases, but a different outcome depending on the dose. And if anybody knows of that, it'd be really interesting to hear about. But as Rich said, the amount that goes in initially is just to get the infection established, and then there's this huge amplification that happens after that, and that's what causes the rest of the disease process, is my understanding.
A critical and insightful line in this letter is that she acknowledges, I'm ready to believe that pipetting virus in saline into an anesthetized mouse's nostril is not the same as someone coughing into someone else's face. Yes. And that's the difference between the reality and the experiment. We just don't know what the natural situation is.
Yeah. And the healthy young people getting sick, I mean, I think that's just the bell curve, right? This is a disease that does disproportionately affect older people, and there's a very clear age skew in the deaths and in the severity of the disease, but that does not mean that anybody is zero risk. Yeah. Yes. And so, there'll be healthy young people who get really sick from this, and there'll probably be healthy young people who die from it. They had a much lower chance of that, but having a lower chance of something doesn't mean it's not going to happen.
All right. The next letter we need probably to ask Daniel. It's about whether you could use a BiPAP or a CPAP machine to help patients breathe. And I don't know, but, listening to what Ori said a few weeks ago, there are a couple of stages where you have a nasal cannula or a mask and then intubated. So I guess it would depend on, I don't think the cannulas are in short supply, right? It's the vents that are in short supply.
The vents that are the big deal. Yeah.
And I don't think you can replace a vent with a CPAP. Okay. That's my uneducated.
We can run this whole thing by Daniel, because actually it's proposing a design for an improvised machine. And the next one I think is also one for Daniel. So basically, Matt is asking, how scared should someone with well-controlled medical issues be? Somebody who's got risk factors, but they're under control.
Yeah, this is a former critical care paramedic. Okay, right.
So we can keep those in the queue.
Okay, I should read Vincent's.
Yes, you should.
It's about the question one should ask is, what is the normal number of deaths in a 19 million city in the winter months, 3 months of cumulative deaths, referring to Wuhan? And what would be the number of deaths if this hospital system is not available for non-COVID-19 patients? And links to a Bloomberg News article that is based on this premise. And of course, all the thousands of urns that we mentioned last time. So he wants to know if we can actually make a prediction of how many deaths there should be as opposed to what's reported. And
I think that's exactly what somebody should be doing.
Yeah, we can't do it. That's for sure.
No, we need some data person to mine obituaries, and somebody who's fluent in Chinese and can access the Chinese newspapers would be, if there's some way to turn those data into feed that into a model where you're looking at how many obituaries are there in a typical period in Wuhan and before COVID-19, and then how many obituaries do you have afterward, and that might be a way to look at it.
Got it. All right, Alan, take the next one, which I think is very illuminating.
Yes. Charlie talks about why fever reduction matters. I'm a surgical resident with fellowship training in critical care. I'm also a master's degree student in a clinical epidemiology program. Fever, typically defined as temperature greater than 101.5 Fahrenheit, is treated aggressively in patients with severe respiratory failure for several reasons. First, fever increases cellular metabolism, which results in increased CO2 production. In order to maintain appropriate arterial pH, this excess CO2 production must be removed through respiration by increasing the minute ventilation of the lungs, tidal volume per breath multiplied by respiratory rate. In patients with ARDS, interventions, that's acute respiratory distress syndrome, interventions that increase ventilation, increase respiratory rate, or increase tidal volume also increase mechanical force on the lungs, which contributes to ventilator-induced lung injury. Specifically, a key feature of treating patients with ARDS is to utilize low tidal volume ventilation below levels that would be seen in a spontaneously breathing person. In addition, interventions to compensate for increased CO2 production often come at the expense of decreased ability to oxygenate the blood. Therefore, treatment of fever, along with other strategies, contributes to more lung protective ventilation, a key tenet of acute respiratory distress syndrome treatment. Second, treatment of fever has also been shown to decrease vasopressor, infusions of medications that increase blood pressure requirements, in patients with septic shock, which is often caused by severe respiratory infections and coexists with ARDS. This is in part through decreasing cutaneous vasodilation under the skin that results from the body's attempts to cool itself. Oh, okay. So your skin blood vessels are dilating to cool yourself off, and then they have to give you pressors to compensate for that. All right, so third, treatment of fever in patients with known or suspected infection has not been shown to have a deleterious effect on ICU length of stay or mortality. And then has attached some references for that.
Oh, interesting. This is all cool, isn't it?
Yeah, very good. We've had discussions before about treating fever, and here is a nice discourse saying, you treat the fever, and telling you why. I had no idea that this ventilation was such a complex issue.
Yeah.
Amazing.
So this explains why my daughter many months ago had a high fever for multiple days, and they were very they tracked her blood pressure very carefully. I didn't know why, and it went down at one point, and they got concerned, and this is why, because your blood vessels dilate to try and cool you off. It's great. I love physiology. Cool. It's good stuff. Rich.
Franciszek writes, so this is a calculation of infection figures. I have a proposal to estimate a level of magnitude of closed cases. Let's assume the actual mortality rate is 1%. There are now about 2,400 deaths in the U.S. So if we divide it by 1%, we get 240,000, which would be the number of closed cases. It would correspond with the total cumulative number of cases from about 2 weeks from now. I know this estimation may be flawed in several ways, but is there something to it? Maybe these numbers may be close to truth. This sounds very similar to calculations that I've seen done elsewhere, and I'm thinking in particular in Kirkland early on. So my own thinking is that this is not far off the mark.
Makes sense. Yeah, I mean, it makes sense if the mortality rate is 1%. If it turns out that we've got a lot of asymptomatic spread and the mortality rate is lower, then the number could be off by an order of magnitude. But based on what we know now, it seems not unreasonable.
No, it makes sense. It's not off the mark. No, I think it makes a lot of sense.
Yeah.
But as you say, we're not diagnosing everyone with COVID-19, and people are dying as well, so it can be off. This comes from Poland, by the way.
Great.
Oh, cool.
1 degree Celsius. It's chilly. It's winter in Poland, right?
Yeah, sure.
His friend recommended TWiV to us. Nice. Oh, she's an expert on virology, but now everyone is.
That's good.
That's right. All right. John wants to know if differences in IL-6 could explain differences in disease severity. Dr. Griffin mentioned something about a drug that moderates a particular part of the cytokine response, IL-6, which may be maladaptive in this case and lead to overreaction and worse disease. I'm wondering if different people might have different levels of this response naturally, and this may have something to do, with the disease course. This might suggest that some people's immune responses don't overact the same way while still being strong enough to fight off the infection, may play a role in determining severity of disease. So he was talking about an antibody to IL-6, which is being tested to try and control the cytokine storm here. And I think so IL-6 is a pro-inflammatory cytokine, and so that is one of the many parts of the cytokine storm. There are others. So it's not just this. And so people who have severe disease may have, problems or SNPs or single nucleotide polymorphisms in IL-6 gene, the IL-6 receptor. IL-8 is another one that's involved, and there are others too. So it's not really a simple thing where one is going to explain it everything, but certainly IL-6 could be a component of it.
Yeah. Yeah. And this notion that individuals differ in their cytokine responses is spot on. And that's something that people have looked at for a lot of diseases. And I know they're looking at it for COVID-19. And I think, what was the episode? Wasn't there one where we had a flu story like this? The patient named P.
Oh, yeah.
Who had an HLA haplotype that made her particularly vulnerable.
Yeah.
It was really interesting immunology. I think Thank You P or something like that was the title of the episode.
We've done a couple of episodes like this where they've drilled down into the genetics of individuals who have responded differently to infection. And more often than not, it turns out to be subtle differences in sort of the network of their immune response.
Right. And John is a mathematician and says he's mostly curious about whether I'm understanding these issues more or less correctly, or if I'm wildly off base. And the answer, John, is you are understanding these issues correctly. This is an excellent, excellent question.
Alan, you're next.
Sure. Portia writes, is it basically asking if it's okay for a couple who live separately to get together? My boyfriend and I don't live together. At the same time as our job shut down, he had a slight cough. After 11 days, his cough abated, and because he didn't have any other symptoms and never had a fever, we felt confident-ish in spending some time together. Am I being irresponsible by expanding my social distance bubble to include my boyfriend, who does not live with me, if we're both practicing social distancing from everyone else?
No.
I don't think you're being irresponsible.
That's my answer. I'm not going to go live in a different house from my wife.
Yeah, I think this is fair. I think, especially, single people these days. This is just an awful situation, and I'm sure, and I think you're being very reasonable. You waited for his cough to abate, and so that sounds fine, and keep your distance from everyone else.
Yeah, and that's part of our condition here is they're practicing social distancing from everyone else. Fine. I mean, a major part of the trick here is not to spread it around to other people. So if the two of you give it to each other, that's just an N of one or two. All right, that's okay. Just don't go spreading it around to other people.
Rich,
Mike writes with a link to a sterilization system for PPE. Love the podcast. On the last episode, you discussed PPE sterilization technology. And as a reminder, PPE is personal protective equipment, masks, gowns, etc. You may have heard about this by now, but Battelle Labs in Ohio has developed machines that can sterilize 80,000 N95 masks a day, currently pushing for FDA to approve use. Cool. I did not know about that.
Yeah, I saw this in the news.
Do you know what the technique is? Do they say what they're doing to them?
What was this one? Was this an ozonizer or a...
I don't think it's... I'm not sure it says.
Remember, I don't remember if they even disclosed what the tech is.
Right. Oh, wait,
doesn't say, no. Doesn't say. Let's see. 2 machines that do this.
But they're building it into shipping containers so that it can be just, put on trucks and trains and sent out everywhere.
Yeah, this is reaching national attention. That's good. But we cannot tell what it is. They're not telling us.
Yeah.
Wait a minute. Battelle process uses vapor phase hydrogen peroxide.
Okay.
To sanitize N95 masks.
There you go.
Cool.
Okay. I think this is an example of the ingenuity that's happening.
Yeah.
It's great.
Cool.
All right, Mike. Links to we talked about 3D printing and how it would work for face shields. So Crystal sends us a link to how they're doing it in the San Francisco Bay Area at a local maker studio, and some more links to the design and their Facebook group. So they want to help out, and they're making these face masks. There's some shields that are being 3D printed as well. Yeah, it's cool. Yeah, I think every bit is good. Alan.
Brian sends this was about our discussion of ozone as a disinfectant. Says, during university, I worked at a fairly low-rent motel, and we would use ozone machines in our smoking rooms to reduce the smell after a heavy smoker. There were significant safety warnings and precautions when using it. No one in the room while it's running for X hours afterwards. Hadn't thought about those in years, he says.
I had no idea that such a technology was available.
Didn't know that was used in that context. I guess that it would explain some of the smell in low-rent motel rooms.
Yeah. Ozone's pretty nasty stuff, I think.
Yeah. We want it in the upper atmosphere, and we don't really want it anywhere else.
So if you want to use it to sterilize, it has to be highly regulated and controlled, basically.
Yes.
You can't do this in your house, right?
No.
Rich.
Severin writes, I'm a master's student in virology. Oh, he's from Iran. A master's student in virology, and I proudly translate highlights of your podcast on my Instagram page. I wanted to know about herd immunity regarding SARS-CoV-2. What percentage of a society should contract the virus in order to gain herd immunity, to your assumption? Once again, I refer back to Barrick's conversation and several other resources I've heard as well that suggest that herd immunity starts to kick in at about 70% of the population immune. I also looked up the other day what the seroprevalence of the existing human coronaviruses was. And I found data for, I think this was just one of them, and 80% for that particular virus, 80% of the human population are seropositive, 50% of school-age children. So that would suggest to me that, in fact, in adults, it's higher than 80%. And it's perfectly consistent with Ralph's model that at equilibrium, you have a high enough percentage of the population to maintain herd immunity, and you get new infections in naive individuals that are born into the population, but they don't get as severe disease. And you get maybe some reinfection due to waning immunity in adults, but those reinfections are not as severe. So you can happily ramble on with about an 80% overall population immunity and maintain the virus percolating through and a fairly low burden of severe disease. Not none, but fairly low burden.
Interesting.
So I really like that perspective, like in quotes. But that's the suggestion is that the short answer is starts kicking in about 70%.
Yeah.
Usually here when people talk about vaccines, that they try to achieve up to 90% immunity to maintain a really good herd immunity. But I think that's to get no disease whatsoever.
It also varies from virus to virus.
Yes.
If you have something ferociously contagious like measles, herd immunity is going to require higher population immunity.
Yeah, there's a formula using the R naught that you can
Right.
use to calculate that, right? I'm very interested that Severin is from Iran. I don't know how many letters we get from Iran, but nice to hear from you.
Great.
Glad you're listening. Next one's from Tom, who's asking a huge favor. My daughter Arabella has wanted to be an infectious disease doctor for at least the past 3 years. She just turned 17 and listens to TWiV. She was unable to have her birthday sleepover with her friends because of SARS-CoV-2. Would you please give her some ideas to inspire her about her future career? Okay, here's what I'm going to tell you, Arabella. Because you listen to TWiV, you write us a letter which will pass on to Daniel Griffin.
Oh, what a great idea.
And he is an infectious disease doc, and he's awesome, and he will give you great advice. But you have to write us a letter, and your dad can help with that. Well, you're 17. You know how to do it. Sorry.
Yeah, you can write us a letter. Send us a letter. And Arabella, happy birthday.
Yeah, and they're in Maine.
They're in Maine?
Yeah.
Are they?
So
thought they were
snowing
in
here in
Australia.
Maine. 0 degrees and snowing.
Sorry. This is good. I have to say, love Vincent's statement. We are only who we are.
Yes.
Yes, because someone said.
Only a medical student.
Yeah.
Yes, you are only who we are. I do think that's true. Now it's snowing in Maine. Wow. That's cool. Alan.
Jody sends a few things. One is a photo of a socially distanced press conference. This is in Seattle. And says our highly competent and science-loving Governor Jay Inslee is in this press conference, and it's a good photo. Everybody's doing a very good job. They've got a whole bunch of people standing around on stage, but they're all separated at proper intervals. I hope this was shot through something of a telephoto lens because it looks like the press corps is not doing as good a job. And I would urge my colleagues to honor social distancing as well because it matters for you too.
They seem to be close together, don't they? The press.
Yeah, the press look like they're pretty crowded together.
They look like they're a little clumped up, and I could see some improvement there. Jody continues, the interview with Ian Lipkin was wonderful. How generous of him to share his vast experience, knowledge, and recommendations, even while suffering through an active infection. And I would second that. That was a great show. Could you please discuss how people might reuse masks they currently have? Could they set up numbered brown paper lunch bags and cycle through the masks, carefully removing them using gloves to deposit them into the bag in a 3 to 5 day rotation? And this is for members of the general public who may or may not be infected.
I don't know about reusing. I just don't know if it's safe. Who knows how many days you would need, right? To make. She's talking about having the infectivity go away.
Yeah.
Right. So I don't want to give any recommendations. I would say keep
wise.
it in a bag for 3 months. How's that?
Right. Keep it in a bag until we're done with all this.
Yeah. What she's suggesting is logically based on the information that we've given about the half-life of the virus on different surfaces. So what she's suggesting is logical, but I wouldn't, we're talking about whether or not people are going to get infected and sick here. And I'm not willing to bet money on whether or not that's going to work.
Yeah, especially healthcare workers, right? We don't want them to get sick.
Yeah, but if this is for the general public and we're talking about people masking up to try and protect from spreading it, because that's a logical possibility. I think at this point, since masks are unavailable and should be going to hospitals anyway, we're talking about people probably tying scarves or bandanas over their face, and then you could launder them.
Yes,
because that'll clean them. Run them through the laundry, put them in the dryer, and I'm comfortable saying that that's getting rid of the virus
for sure.
But if you've got disposable masks and you're going to try and rotate them through bags, I don't know.
By the way, Jody says, uses the word inactivated. Apologies if inactivated is the wrong word. I'm pretty sure Vincent wouldn't want me to say killed. And you are spot on, Jody. And I have to say, I have to bite my tongue during this outbreak because so many people are saying killed and live virus, but I just don't want to interrupt and make a pedantic pest of myself. But I can deal with it. It's not a problem. Rich, can you take the next? It is inactivated,
yeah.
It is. Rich.
So this is from Aaron, wondering about food safety and fecal oral transmission of the virus. I'm writing to you from Oahu, Hawaii. We're only just now starting our climb. And in fact, I just looked it up. Hawaii has 204 cases and no deaths. An article was posted about food safety, and I wanted your take on it. We'll go back to this. A lot of us have been he gives a link. A lot of us have been very worried about fecal oral and wondering why there hasn't been, as far as I can tell, reports of mass exposures due to food. The article makes it sound like it would be very difficult to get the virus from eating it. What do you think? In the extreme end, how dangerous would it be to lick a surface with virus on it? Okay. I haven't looked at this article. Have you guys?
So it is basically a lot of the stuff that Kathy pointed out on Friday. There are a lot of articles she linked us to from who takes care of food safety in the U.S. What's that organization?
That's now? The FDA. The FDA mainly,
no,
right?
USDA.
USDA and FDA both, right?
And the FDA both, yeah.
And as Alan said last time, I pretty much remember this. We don't have any evidence for foodborne outbreaks yet.
Right.
Doesn't mean they won't happen. But so the thing is here, all right, if you have food contaminated with SARS-CoV-2 and you chew it, I am sure that would make an aerosol that would infect your mucosal surfaces and your oropharynx, right?
Okay.
So that could start an infection. But in principle, it should be possible to get a respiratory infection. But we haven't seen any of that yet. Maybe it'll come out later. So, and if you have people serving food and giving you utensils, all of those are potentially touched by the people. So I don't know if it would show up as a foodborne outbreak. Right?
I just think standard food safety precautions that everybody should be doing anyway. This is a great time to review those. And Kathy pointed out a link to, I think it was an FDA site that went through, or foodsafety.gov, which is a joint FDA, USDA type project. Just, look through that, follow those instructions. Restaurant workers, at least in the U.S., are required to have training in food safety, and anybody who runs a restaurant or works in food safety has to take a course and get a certificate saying that they've done this. I think for like line cooks, it may not be necessary, but anybody who's managing this and setting up the processes. So if you're concerned about the way a cafeteria is being run, you can find out about what they should be doing and what they shouldn't be doing. Vincent's point is good. It could maybe spread through food, but if the food is being handled properly, it seems unlikely.
This article is written in a frequently asked questions or question and answer sort of format. And there's one question here that really strikes at me. Says, does Chinese food pose a greater risk than other food? And it's exasperating. No.
Yes. No. The answer is no.
Yeah, Alan was saying yes to exasperating.
Yeah, it's...
So the other question here is, could you get a GI infection from eating it? And yeah, in principle, you could. But I don't know where that goes if you infect your gut first. Right? Because I just don't know the sequence of events. And it's a really interesting question. If you get a gut infection, can that spread somehow to your lung? We have no idea. But maybe you could get GI symptoms. Some people are saying they just have GI symptoms. So maybe there's a separate, right?
Daniel described a couple of cases that showed up initially with GI symptoms and progressed to respiratory symptoms. Now, whether that's all due to the same disease or what, I don't know. And it's an anecdotal story. I'm sure that these are things we will find out, but it's worth thinking about.
And don't lick surfaces.
No. I would discourage you from doing that.
Yeah.
No, I would. My answer would be depends how much virus is there, but
Yes,
that wouldn't be a good idea. You'd get infected most likely, right?
with something.
Wash your hands.
Yeah,
Yes, wash your
wash your hands. I tell my students don't eat the mints at the restaurant cashier, but nobody's going to restaurants anymore, right?
Yeah.
All right, so now we are on to this thing is acting.
Brian.
Here we have Brian. On the most recent TWiV, it was mentioned that fruit veggie soap washes, while they may be inferior to cold water rinses, they weren't harmful. If you look at the MSD sheets for dish soap, there are GI symptoms after ingestion of soap that may mimic some early COVID-19 symptoms like mild nausea, vomiting. So the public health messaging usually avoids soap washes for fruits and veggies, at least here in Canada. Okay.
Cool.
But I think if you rinse really well, wouldn't you get the soap off?
Yeah, but I think the standard food safety advice in the U.S. too is don't bother with the soap in the first place.
Okay. Sorry to mention that. It was a recommendation from an NIH scientist.
Yeah, so the soap, there are, and I think this is maybe what Brian is talking about, there are vegetable wash products that are sold in the store, and I guess those have been vetted for being safe for this purpose, but Brian is not convinced they're effective, and yeah, just rinse it with water.
Okay. Alan?
Isabel writes, we're watching Chinese authorities deciding that life can go back to normal in the first affected areas. If the quarantine was effective in stopping the infection progression, wouldn't it also shorten the collective immunity? What is preventing it from starting and spreading all over again? That is the question on everybody's mind right now. Isabel is in Lisbon, Portugal. And yeah, they're lifting the quarantine, and I know the Chinese authorities are watching closely to see what happens, and the rest of the world is watching closely because we all hope to be in the similar situation in a few weeks. And I don't know. And your point is exactly correct. If the quarantine really stopped spread, then we won't have herd immunity, but who knows?
Okay, that's it. Rich.
Anonymous writes, I am a paramedic and emergency department nurse. Quick note from the field. My state is right in the middle in terms of the number of confirmed cases nationwide. We have enjoyed fewer patients in the emergency department over the last 2 weeks, but they are beginning to creep up. We have had several positive cases, and those numbers climb every day. Results come back. Currently, the tests are averaging 8 or 10 days for turnaround. Wow. Everything you are hearing about shortages of PPE, ventilators, staff, etc., is coming to life in my department at an agonizingly slow pace. The worst part is that it seems to me that we have had so much time to prepare and make space and utilize existing supplies of PPE to contain and isolate suspect cases, but we were so undecided as how serious to take this that it is now too late and we can only react. I was in the military many years ago and was part of the U.S. Marine Corps Chemical Biological Incident Response Force. It seemed we took it seriously, and the nation as a whole had a response plan that would be in place as a global pandemic was all but certain to happen at some point. It deepens my anxiety today, knowing that that simply wasn't true and that our civilization is still so fragile and ruled by utter complacency. Hear, hear, well said.
Wow. Perfect.
All true.
And I think it actually was more true back when, because you said, this is talking about the early 2000s that we're being prepared. I think that at one time we were much better prepared. And in just recent years, we have let that fall apart because we felt like we didn't have to keep paying for all this stuff we weren't using anymore. And here we are.
Now we have we have paid for it many times over, haven't we?
Oh, yeah.
Hopefully we will learn.
Yes.
It's interesting. This reminds me about the difference between just preventative medicine and reactive medicine.
Yes.
You know, we need to take measures to make sure we stay healthy.
Don't we say something like an ounce of prevention is worth a pound of
That's
cure?
it.
Maybe that should be our episode subtitle.
Yes.
Oh, yes. As a matter of fact, that's good.
All right, from Annie, who is an update status from Taiwan. We have 298 confirmed cases, 2 died as of March 29th. The government banned surgical mask export from January 24, and people started hoarding all kinds of masks, 75% alcohol, detergent of disinfection. We have also been through the chaos of hoarding food and toilet paper. And finally, people calmed down. The digital minister, well, that's an interesting title.
Yes.
And the IT team set up the system containing the health insurance, and everyone can buy 3 surgical masks per week with less than $1 US at pharmacies or via pre-booking online. There are lots of clips reminding us of personal hygiene, wash your hands, which might contribute to the decreasing of influenza spreading, and she provides a link to that. Quarantine with multiple languages played on almost all TV channels and media platforms. Minister of TFDA and the team hold press meetings every single day since January on TV, and live stream and social media accounts automatically update the status. Restriction for traveling gradually changed to grade 3 warning to all the world. Compulsory quarantine for 14 days is required for people who come from overseas. People start working from home or in different areas, and body temperature checkpoints are set at the entries of building. I work in the pharma company, and we noticed the enrollment rate quite low recently in Taiwan. And the U.S. FDA guideline for clinical trial provides a link to that. I remember one case in Taiwan in the early stage was using different typing, L and S types, to differentiate whether the subject is more likely to be infected by the local strain or by the strain from overseas. Will this only apply at the early stage? And is it no longer applicable after the pandemic? So thank you for the update. It's really good to know that some countries did this really early and very thoroughly. This is great, all these things being done.
There is a right way to do this.
And then this business about 2 strains, L and S, we talked about that a few times in the past, and they are just sequence diversions of the virus that happen, and they really have no impact on disease or transmission or virulence or anything. So they are not really anything to be concerned about.
She's asking whether they can be used to determine whether a person is infected by a local strain or a strain from overseas. So are those types geographical markers? Did those types come from different places? I don't recall.
Well, they first diversified in Wuhan, right?
Right. Okay. So they both come from the same place initially.
And was this the one that was a single nucleotide change?
I think so. Yeah, it wasn't a big deal.
Yeah, because I don't find that especially compelling for anything.
No.
But the experience in Seattle was that they could sort of say this, that strain first came over here, and then everything has that particular SNP. So it was all derived really from one person, right?
Okay.
That's the least complicated explanation, anyway.
Right.
All right, we just do. Let's do one more round here, Alan.
Matt wants to know how does hydroxychloroquine therapy work? How does an antiparasitic and an antibiotic, hydroxychloroquine and azithromycin, work on a virus? Damn fine question, Matt.
I've been meaning to comment that when a scientist says, that's a really good question, that translates to, I don't know.
I have no idea. Yeah.
There are a couple of possibilities. So the hydroxychloroquine has many effects on cells and probably has multiple effects on viruses. And one of them is to raise the pH of the endosome, which affects the entry of many viruses. But that's probably one of a number of ways that it's working. So it's an antiparasitic, but many drugs do affect other organisms like that. And then azithromycin is an anti-inflammatory it's also an antibiotic, but it's also an anti-inflammatory. And so that may help patients as well, because as we have said, we have issues with over exuberant immune responses.
And hydroxychloroquine also has effects on the immune system, which is why lupus patients are taking it.
That's right.
So it might be that this combination is doing more in tamping down the cytokine storm or some negative aspect of the immune system than in it actually. But yeah, we don't know.
One thing I would say in general is that lots of times when we talk about antivirals or even antibiotics, you're talking about drugs that act directly on the pathogen. Okay. Another presumed route of treatment is to act on the cells that the pathogen is interacting with to make it an unhospitable environment for the pathogen. And from what we know, I would say these things, hydroxychloroquine and azithromycin, fall in that latter category. They're affecting the status of the cells that the virus wants to affect, infect, rather than acting directly on the virus replication.
And let's also bear in mind that we're still waiting for the big randomized control trials that show that these really do work. We've got some tantalizing preliminary stuff.
Sure.
But if it turns out that these don't work, then this whole discussion, how do they work, would be, well, maybe not. But yeah, we're hopeful.
I think it's amusing that Matt says, can you help us in the lower rungs of healthcare? I think we're all important, Matt, in some way.
Yes.
Rich.
So Noel writes, I'm a registered nurse currently working in the cardiac intensive care unit. Should be backup ICU for COVID positive ventilated patients. I'm wondering, what are your thoughts on frontline healthcare workers leaving the family and home for the duration of this crisis? I'm concerned about potential exposure of myself and currently those I live with, but also worry about how long this will go on for and how long that separation would be for. And I think these are, so in other words, you just stay at the hospital. I think that's a personal decision, and we don't know how long it's going to go on for. I think it's going to be weeks, at least. And boy, I wouldn't want to leave my family out for that long. And beyond
on an extremely selfish note, I recommend against this, but that's just because my wife's working in an emergency room. But and I want to see her. I think this just really illustrates. I mean, this is really poignant, right?
Yeah.
These are the kinds of decisions that people are having to make, and my wife's not in direct. She's not respiratory therapy or cardiac intensive care or anything like that. But for folks who are really, really up in the face of this, you want to protect your patients and be there for them, and you also want to not expose your family. And I don't know what to say.
I would agree. I think your family gives you a lot of psychological stability.
Yeah.
Somewhere we have to find a balance between mental health and your physical health.
And that's important. I think you do your job better when you go home to your family. So
yes.
I think you should just be careful at work, right? Take all the precautions and don't have any gaps, and you should be okay, right?
And I think Daniel Griffin had some good pointers on this. He comes home, he strips off into the washing machine, immediately showers.
Yep.
And I would say if you have high-risk family members at home, maybe elderly relatives living with you, if you can somehow sequester yourself away from them, that would be really helpful. But just, be careful and be with your family.
Did you guys did that come over I tripped a YouTube video. Did you hear that?
I didn't hear
anything.
Okay.
No, I didn't hear anything.
Came just through my headphones, nearly blew my head off.
Noel is from Calgary, Alberta.
Okay.
So thank you. And with one more from Megan. Thanks for all that you do. Love your work always, but especially at the moment. See this link, which is designed to show kids how to effectively wash their hands, made by my friend, the talented Rena Fu. And Megan is from University of Western Australia. I just love the international engagement we're getting. We always do, right? We always get a lot of that, but even more so now. So thank you very much. And that
Wonderful.
is our another TWiV, which is 596. And by the way, I know this is an upcoming email. We'll read it another time. But as many of you know, I was inspired to start TWiV 12 years ago, because I was listening to This Week in Tech, which is the creation of Leo Laporte, and that's why this is called This Week in Virology. And apparently he mentioned TWiV on one of his shows, This Week in Google, actually, and recommended that people listen to it. So how cool that it goes around.
Yeah.
to back to where it started. You can find this podcast on any podcast player. Please subscribe so we know how many people are listening. You can find all the show notes, including the full text of the letters, at microbe.tv/TWiV. Please send us your questions and comments. TWiV at microbe.tv. We will get through them all. And if you really like what we do, consider supporting us financially. Microbe.tv/contribute. Alan Dove is over at turbidplaque.com. On Twitter, he is Alan Dove. Thank you, Alan.
Thank you. It's always a pleasure.
Rich Condit's an emeritus professor, University of Florida, Gainesville, currently residing in Austin, Texas. Thank you, Rich.
Sure thing. Always a good time.
I'm Vincent Racaniello. You can find me at virology.blog. Thanks to ASV and ASM for their support of TWiV and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.